Recently, I gave grand rounds on some upcoming changes in medical education in Canada in late June of 2013. Uh, I was asked after these rounds to record what I had discussed that morning. So I have recorded my voice over some of these slides for rounds. The outline of what I'm going to talk about includes, firstly, who are the big players in medical education in Canada, and just some definitions so we're all talking the same language. A little bit about how we do things now, how do we train physicians now in Canada, some discussion about competency-based medical education, and finally some challenges with regards to competency-based medical education. Really, if you look at how we educate doctors in Canada, there's 5 main phases. Pre-medical training, or term people use, be pre-med, really all over the map in Canada. Science, social sciences, arts, engineering, masters, PhDs, all come into medical school. In fact, there are or is a program being undertaken shortly, I believe, in Kingston, looking at bringing students directly out of high school into some form of medical school. Then obviously there's medical school itself, which is anywhere from 3 to 4 years in Canada, mostly being the 4-year programs traditionally. The focus of my discussion today is going to be on residency. Then there's fellowship training, or in some cases people may call that subspecialty training, although really in Canada subspecialists are still residents as their training. Fellowship is slightly different than that. And then continuing medical education, which is only the one line, however, would make up the lion's share of what most physicians would have for their education through their career as far as time goes. 20, 30, 40 years of CME in a career in medicine. Some quick definitions. Most of us know this, I think, already, but the definition of a specialist versus a family physician in Canada, at least. A specialist is a physician trained to possess and deliver knowledge, skill, and attributes of a given specialty. It could be medicine, could be surgery, or it could be a specialty that kind of falls somewhere in between those two domains. Some would say maybe anesthesia doesn't necessarily fall neatly in one of those two spots. Family physician really is same definition as a specialist. However, the skills a family physician would possess and the knowledge is really about primary care, and those skills appropriate to family practice and care of patients in the community. Who are the important players in Canada for training physicians? Certainly the Royal College of Physicians and Surgeons of Canada. That's where people get the FRCPC or the FRCSC, depending if you're a physician or a surgeon in that group. They really control and accredit the training of specialists across Canada. And also they control and offer and track continuing medical education for specialists in Canada. The flip side of that coin, or the group for family physicians, would be the College of Family Physicians of Canada. Really just the same as the Royal College primarily, but for family physicians. The training, CME, exams, all that for family doctors would go through the College of Family Physicians in Canada. Certainly the hospitals and the departments and the divisions within the hospitals have a big impact and stake in education of the residents in Canada, and also have a big stake in the service aspect of what those residents offer those hospitals and those departments in Canada. Universities, the biggest link would be through the program directors of individual programs during residency. And the universities are obviously primarily interested in education aspects of the residency. And then the kind of an overarching body, at least in each province, would be the Ministry of Health and Long-Term Care. That would be the title in Ontario. And they offer the money to pay the residents, and they also certainly have interest in the service those residents provide and how the training programs are divvied up in the country, how many spots are available for any given type of specialist in the country. The Ministry of Long-Term Care and Health have certainly interest in that, amongst other things. So if we look at what we do now in Canada, some would call it the tea steeping model. We put a resident in a clinical environment for a number of years, 2, 3, 4, 5, 6, 7 years, and we see at the end, what do we get? Do we get a nice cup of tea? Do we get the nice physician with all the components that we think a physician should offer? The skill, the knowledge, the attributes that a highly trained family doctor, surgeon, internist should have for their patients in their community. We hope that we do get that just through the simple exposure and learning by osmosis to some degree, being in that clinical environment, and being in that clinical environment quite a bit with the amount of hours in particular some residents would work. I was asked whether the resident was the water or the tea bag. I wasn't quite certain how to answer that question. I guess it depends on your perspective as to which is which. In residency now, it's primarily time-based, and you'll see why this is important down the road in this presentation. But if you look at how we train residents now in Canada, we can look on the macro level, the number of years the residency takes. So 2 to 3 years to be a family doctor. The third year would be for those doing an extra year of training, such as in emergency medicine or anesthesia, and some other enhanced skills programs in the country. 4 to 6 years to be a specialist. And then 2 to 3 year kind of subspecialty programs, such as cardiology, respirology, and thoracic surgery would be examples of programs such as that. And certainly the program I was initially presenting this for, critical care medicine, would be an example of a subspecialty program. You can look on our residency programs in a micro level as far as time-based. You know, a lot of universities in Canada are on the block system now, 4-week blocks, or traditionally a 1-month block of training. And each block or group of blocks would have a specific set of goals and objectives and an evaluation attached to those goals and objectives for a specific type of training. And you know, we have the traditional type of interns. There's still versions of internships, although they don't like to use that term anymore. PGY1 or R1 is typically what we talk about now with people in their first year of training. And then you move up the ranks. You move up to being a junior resident, and move up to a senior resident and chief resident, with theoretically increasing levels of responsibility. And you may be teaching the more junior residents and medical students as you get to those senior levels. And then all the specialties and family medicine have a big exam at the end. The exam that often has a written and oral and maybe OSCE component to it. And certain programs would have an exam somewhere in the middle or towards the beginning. The principles of surgery exam would be an example of an important exam in the middle that people must get past to progress in their training and to be able to sit the Royal College exam or a similar exam at the end of their training. I'm sure almost everybody has seen this picture before. It's how we've been training residents, at least specialists in Canada over the last number of years. The CanMed's roles, the 7 roles, with medical experts being the central role, and the other roles all impacting on that central role and overlapping with each other. No one role necessarily more valued or more important than the other, with the possible exception of the medical expert aspect that sets the physician apart from the non-expert. in their domain, and really is the guiding principle of how we train physicians in Canada. All of our trainees have to be able to demonstrate competency, and we'll get to that a little more, or maybe demonstrate at least the ability to do this down the road. But things are changing, and you'll see that things are changing as we get through this presentation. And the question is, do things need to change? Do we have a problem in Canada with how we train physicians? And the question would be, do we pass or graduate residents that aren't competent, or at least minimally competent? I would hope most of us wouldn't want to end up in care of a doctor who we would term minimally competent. We want somebody who demonstrates excellence and extraordinarily competent, not necessarily minimally competent. It depends who you talk to, whether we're graduating residents or passing residents through the levels of residency that we wouldn't even call minimally competent. And it depends on the time frame we're talking about. Do we let somebody go through 1 month or one block of training, or maybe just from PGY 1 to PGY 2, or through their whole residency with not feeling they're truly competent? I'm sure we've all heard of the resident doing a rotation and their supervisor's thinking, well, they just had an off rotation. I'm sure they'll do better next block, next month will be better, and so they pass them along. And same would apply to PGY years. The PGY 2 who struggled through PGY 2, people want to give them the benefit of the doubt and pass them along. And unfortunately, sometimes there are residents that get to PGY 4 or PGY 5, and those same comments are still being said. And by that point, it's getting pretty late in the game to suddenly sit somebody down and say, you're not achieving what you need to achieve in residency, when those things probably should have come to light much earlier, in fairness for the resident, in fairness for patients, and in fairness to those that are paying for the residents to get trained and get out and practice. Other question would say, do all residents in Canada get the same level of evaluation? I would say certainly not. From month to month, block to block, year to year, university to university, training program to training program within the same university, the level of evaluation is all over the map. There are some residents can go through a block or a certain site, a certain hospital, and not even meet their supervisor. Other residents will get daily feedback and will have lots of sit-down discussions with their supervisors, have oral exams, OSCEs, observe encounters with patients. It's really all over the map, and certainly the Royal College and the College of Family Physicians try to even that out as best they can. But right now, I'd say in Canada, it is not a consistent level of evaluation. And are patients being harmed by this type of training, this model of training that we have in Canada, this T-steeping model? I'd say certainly trainees cause harm. There's no doubt about it, that if you're learning, there's probably a higher incidence of harm coming to a patient. I'm not talking necessarily about significant mortality or morbidity, and maybe there is some more of that, but even something that people may not think is harm. A woman in labor needing an extra 10-15 minutes to get the epidural placed because a resident is more junior in training, 10 to 15 minutes longer in pain discomfort. You could argue that harm came to that patient because of that training, but we would think that that's how physicians need to be trained. But is there a different model that shows that less harm would come to patients? Is there a comparator we can say, well, if we did this, patients would be safer, less morbidity, less mortality? Don't think we have that evidence. At least I'm not aware of evidence to say that another model causes less harm to patients. And then there's the issue or the phenomenon I refer to, at least, as the participation badge or participation ribbon phenomenon, that a lot of people, if you talk to any parent, you'll hear this as well, and teachers and things like that. And to some degree, people think this happens in residency as well, where just by showing up, just by being nice and not causing any waves and getting through and being on time and that type of thing, people get moved along. They get their badge to say thanks for showing up, and we'll give you this, and just move along. And didn't necessarily have to demonstrate any great skill or any significant critical evaluation of your performance. Everybody gets the same badge, and you move along. There are no winners, there are no losers. Everybody just moves along, and that's their participation badge. That kids would get. Even the stinkiest kid on the soccer team gets the MVP trophy at the end of the year because everybody's the MVP. That's not necessarily the way I think the public would want physicians trained. I think they would want a more critical evaluation of physicians' training and expertise as they move along in training. And I think that is of great concern to the public as to what really are you saying when you're saying somebody is moving along in training and moving up the ranks in training. What do you actually have to show that they're actually gaining the skills and being excellent at the skills they should be getting excellent at? I think there are also some benefits to the time-based model. It takes time for people to mature in a residency. I think, as I've said, I think we've all thought of a resident maybe as a PGY1, PGY2 wasn't quite making the grade. And luckily, most of those residents actually do start to turn around. And I think a lot of it has to do with maturity. They start to see their colleagues progressing. They start to realize that they're getting maybe towards the end of training and that they need to put their nose to the grindstone and start making sure they have the skills to function properly as a physician. And I think it takes a little bit of time to get there. And for a specialist, after 4, 5, 6 years of training, I think people do mature and are more ready to integrate that knowledge and accept that knowledge and accept the criticism, constructive criticism, that they need to hear to improve and become a well-rounded physician. Time-based also is very predictable. We generally know how many residents we're going to have, what the cost of that training is going to be. If you have 9 residents entering your first year in your training program, you're pretty sure, roughly, that about 9-ish residents, give or take, people on parental leave and that type of thing, are probably going to be finishing your program in how many years your program takes typically to finish. So it gives you lots of certainty. Call schedules are a great example of this. You know how many residents you're going to have to do call schedules, and the hospitals are very interested in making sure they have enough house staff to cover those schedules. And we've done it this way for at least half a century, if not a century, of this type of training. And I would argue generally with good results. I think for the most part in Canada, we are producing high quality, well-trained, highly motivated specialist and family physicians. I think the results are good. Our model of training is being exported worldwide. We are an example to be held up for others to follow. So I think, despite people's misgivings, I think overall in Canada, we are producing excellent physicians and surgeons and family doctors. It's hard to argue against that. But then this word competency comes into play. And you're going to hear a lot about this over the next number of years. And for program directors in the country, no matter what specialty you're the program director of, this is going to be your life for the next number of years, getting your programs into a competency-based type of system. And for anybody that can tell me what this cartoon represents and what it's from, extra points to you. So a few things or definitions of competency. I get all my medical information nowadays. I Google everything, as do all my patients. So competence, the quality of being adequately or well qualified physically and intellectually. Well, it's not a great definition for competence as a physician. Oxford doesn't really offer us much more about the physician. I think the last one, which is a definition I lifted from one of my colleagues' presentation from Ottawa, Vern Nake, gave this as a definition of competency. And the last one there, an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. I think that's as close as I can come to what competency means to be a physician. This slide's also stolen from Vern Nake, and it's really how the Royal College, or some of the history as to how the Royal College started to move towards competency. There was a report published in 2009, Directions for Residency Education, and within that report, they demonstrate a desire to move towards a competency-based education system across all specialties, and they want to move, as they say, into the 21st century and move away from the tea-steeping type of model, or at least partially move away from that model. And it's going to be everywhere. I did say it would be the life, or maybe the nightmare potentially, of program directors across the country, of associate deans of postgraduate education. Wherever you go, this is taken from the Royal College website. It's heavily marketed now on the Royal College website, the competency-based aspect of medical education, and the Royal College is laying the groundwork, moving education in Canada towards competency-based education. If you look through their website, you'll learn lots, and I certainly have learned lots reading through that website, with lots of good links about some of the data and research behind the move towards competency-based medical education. The Royal College isn't necessarily going to call it competency-based medical education. The catchphrase for the Royal College likely will be competence by design. Will be what the Royal College uses to say competency-based medical education. And you'll likely see this plastered across many pieces of letterhead and email communications and websites attached to the Royal College. It'll be competence by design, which I guess is different than incompetence by chance. So how are we going to measure competence in a trainee, or what many of us will have to realize is this is not just for trainees. This is going to likely, I would imagine, move out into continuing medical education, that we as practicing physicians, finished our training, so to speak, will have to demonstrate some competence. And how that's going to look, I'm not completely certain, but I would imagine it's likely coming. But for residents, and maybe faculty too, but for residents, two terms come to mind: milestones and EPA, which is entrustable professional activity or activities. These are two methods which are overlapping and interacting methods as to how the Royal College will want to measure competency. And I'm still getting my head around these terms, and so if I get them mixed up and vice versa, I'll apologize now. So what is a milestone? Descriptor of abilities or competencies at a specified stages in the development of competence. So the milestone of a first-year resident is going to be different than the milestone of a senior resident, or as a practicing physician. The milestones will be different. Entrustable professional activity is something we may use to measure a milestone or measure how a resident is progressing through their training. So it's certainly observable, has to be fairly defined, and it has to encompass a lot of different competencies, or multifaceted. And it's things a resident can do independently as they advance through their training. They may not be doing it independently at the start of the training, but these EPAs will be something we can say a resident will get to a level where they can do it independently. An example may be a laparoscopic technique of surgery. A resident will progress through their training. As they get more senior in their training, they may be able to do a laparoscopic cholecystectomy independently. And that would be now untrustable. You entrust that resident to do that activity independently. They've been observed, maybe on multiple occasions, and maybe observed doing simple tasks with regards to laparoscopic surgery, simulated laparoscopic surgery, straightforward laparoscopic cholecystectomy, a challenging laparoscopic cholecystectomy, managing the complications of a laparoscopic cholecystectomy, gaining the consent to perform a laparoscopic cholecystectomy, talking to patients post-operatively from a laparoscopic cholecystectomy. All these things are observable. You can define it, and they're multifaceted. They don't just have the technical aspects of performing a laparoscopic cholecystectomy. They have the communication, the collaboration, the health advocate. All those aspects would be multifaceted and put into that EPA to say, yep, at this level, this resident now can be entrusted to perform this activity, and it's observed, and they now can do it. So milestones and EPAs will be overlapping. There'll be certain milestones in a resident's training that you measure via an EPA. And the milestones will be dependent on the specialty. The milestone for a anesthesia resident, PGY 2, won't be the same milestones as a general surgery resident as a PGY 2. Some of them will be the same, but certainly some of them will be different. Milestones for a junior resident will be different than milestones for a senior resident. And I guess the theory or the idea is that you can't move to the next milestone until you achieve some level of competency or level to demonstrate that you passed that milestone and you can maintain that milestone. And it's using things like an EPA to say, yeah, these milestones, you've achieved them, you can demonstrate them, and now you move up to the next level of milestones, something more advanced. Moving from the junior, senior to the master level of these milestones. Question about the EPAs though, and if you think of a specialty that has a lot of different maybe surgical techniques, would be interesting for this. A lot of different surgical techniques. So, a general surgeon might be an example where there'd be potentially for a general surgeon there'd be a vast quantity or a vast array of different surgical techniques they may have in their practice, so they could be trained to do. And it'd be very challenging to do an EPA with all the communication, collaboration, health advocate, scholar, medical expert aspects of that surgical procedure, and do an EPA for every single one. So there's an idea of whether you do sampling, just doing the ones that you think are very important or very common or representative, versus comprehensive, doing everything. Everything you can possibly get trained to do, you're doing EPA to demonstrate you can actually do it. Comprehensive would be quite challenging. Sampling maybe a little bit more straightforward, but the concern there is that you may miss something. I took this slide from another one of my colleagues, Dr. Rob Anderson from the Northern Ontario School of Medicine. And just a way of trying to show graphically or through a display interaction between milestones and EPAs. As you can see, you may have one EPA looking at certain levels of certain types of milestones from the basic to advanced to mastery level. Mastery may even be when you're out into practice. And depending on what level you're at, you may have more challenging EPAs to do at each of those levels. So basic level, maybe just, do you know the anatomy? Do you understand the indications and contraindications? To the mastery level, where you can do some form of technique, understanding all those things, but being able to do a very challenging technique and potentially manage some of the significant complications of that technique, whether it be a surgical issue or a diagnostic issue, or what have you, that you're able to do that at an extraordinarily high level. So an example in critical care, as I initially gave these rounds for critical care, milestones again at different levels of seniority. We could think of looking at communicator role. Can somebody effectively communicate with the family? The collaborator role, can you interact with other healthcare providers? And medical expert, can you answer the questions, the advanced questions a family may have about a patient's medical condition? And to get all these milestones and all these issues into some EPA, maybe it would be through conducting a family meeting for end-of-life decisions along with nursing and a social worker. That would have the communicator, the collaborator, and the medical expert aspects all rolled up into one, plus probably a few more. Health advocate would come to mind as well. And that would be a EPA that you could observe, and then once a resident has had maybe one or two, I'm not sure how many, EPAs showing that they can do a family meeting for end-of-life issues, they're now entrusted and they can conceivably do that independently and be at an advanced and potentially even master level for that EPA. Certainly, as I mentioned previously, a resident has to progress through this training system. You may have introductory level EPAs or introductory level milestones, and they may not even be really based heavily on interaction with real patients. Maybe simulated patients, maybe simulators. It may be written tests, oral exams. So there may be some introductory aspects that you can get residents to demonstrate some competency in without actually exposing patients to somebody who's learning the very basics of their specialty. As a junior, certainly would need more patient interaction. Again, tests, simulation, and some intermediate level EPAs that aren't maybe highly advanced, but demonstrating some level of complexity. And then seniors, they may need to get to the point that they can really do most things as a junior consultant would be able to do, and show entrustable professional activities that are at that level where they could practice independently after passing those EPAs. And certainly there's national exams that senior residents must still pass, and other maybe internal exams that they would have to pass too that are at a very high level, potentially prepping them for the national exam. The whole issue on national exams is always of debate as to whether those exams should be right at the end of the final year training or somewhere at the beginning of the final year, or even more early than that, to allow residents to almost function as a junior consultant in the last year of training without the worry of a final exam hanging over their head that entire year. Certainly there are programs in Canada, these are just two that I'm aware of, that are really ahead of the curve when it comes to the discussion of competency-based medical education. Now, I warn you that these are what you might term as time-free models, and competency does not equal time-free. You still can have a time-based curriculum or time-based residency and have competency within that residency. But the University of Toronto Orthopedic Surgery Program certainly was an example of a time-free, competency-based program. It was based on having modules, from what I understand. And they graduated residents this year after 4 years of training, and rumor has it, I'm not privy to the exact details, but I've heard they did well on their exams. And residents may have taken 4 years to do it, they may have taken conceivably 8 years to do it. It depended how they progressed through those modules. And if they did not pass a module, they couldn't pass their residency, so they needed to pass through those modules. A module, for example, might be total joint arthroplasty, would be a module of training. The Ottawa-based program is the anesthesia program, that is beginning to move towards a pilot of a time-free competency-based program. It's going to be based on milestones and EPAs, not necessarily module-based. We'll be having some junior introductory level aspects of training, and then as a resident moves up through that level of training, they'll get onto more senior types of milestones and senior EPAs. And again, it's time free. It depends how quickly that resident could move through the program. So conceivably, residents may finish their anesthesia training in 1 or 2 years less than they would normally, or maybe 2 or 3 years longer than they would normally. Depends how the resident progresses through that program. And again, I'll remind you that the anesthesia program in Ottawa and the orthopedic surgical program in Toronto are time-free. However, time-free does not necessarily equal, and this slide just reiterates that point, not necessarily the same. Competency and time-free aren't the same. I think that's what scares a lot of program directors and a lot of medical schools. You still can have competency within the confines of a more traditional type of residency training. Being a program director, thinking through the challenges of all this, I think it will be quite daunting to have this competency-based curriculum within a program. The rollout is supposedly for 2017. It's going to be all specialties and subspecialties. And this is not a trial. This is not a pilot. The Toronto program and the Ottawa anesthesia program are trials of a time-free curriculum or time-free type of competency-based training. But the idea of competency-based medical education or competency by design, it's not a trial. It is how the Royal College is planning on moving forward with training in Canada. Certainly things may change if it doesn't go well, but it's not something they're just going to see how it goes for a while. This is what the Royal College wants to do moving forward. The biggest difference, I think, in the type of training between the T-steeping model and the competency-based model is really evaluation. I think if you talk to the residents and the faculty at the University of Toronto for the orthopedic surgical program, one of the biggest things is the residents were evaluated in a much more frequent and maybe rigorous manner than other residents would be evaluated. Maybe you could say the accuracy of the evaluation is different because it's different methods of evaluating, but certainly the volume and frequency of competency-based programs would far exceed the traditional T-steeping type of evaluation frequency. And I'd also say one of the biggest differences would be the consequences of those evaluations. Again, kind of the participation badge issue where you get an evaluation where you do fine, you do all right, you're not great really, but you're not terrible either, and you pass along. If we're really to talk about competency-based medical education, being just sort of okay is not good enough if you're going to get to that advanced level. You need to demonstrate actual level of competence and advancement of skill, knowledge, attitudes through milestones and EPAs to get through your residency. And so that will change the consequences of the evaluations and potentially increase the stakes of those evaluations for residents and programs. A few words about CanMeds 2015. As I alluded to earlier in the discussion, the 7 CanMeds roles, which you can kind of see off to the left of the slide here, are still going to be there in 2015, but there's going to be some additions to the CanMeds framework in 2015. So again, the same 7 roles in 2015, from what I gather at least. But they're going to add some other aspects into those roles. Certainly, patient safety is a key phrase across Canada and internationally over the last decade. Patient safety initiatives really have, and rightly so, taken over hospital culture, and we all hope that continues. Interprofessionalism, another key phrase in training, not only in medical school but in many professional healthcare related schools. The aspect of team-based care and how those members from different specialties and within specialties get along as part of a team. As we all know, if the team fails, oftentimes the care of the patient fails as well. And then continuity of care is going to be integrated in there as well. So let me say, before I get into some of the troubles, let me say I think the idea of competency-based medical education is laudable. I think it likely is the proper way to go for educating physicians. And I think in theory it would sound to be like the better model. And I think it will succeed. But there's certainly going to be some challenges. And I think one of them is our hospitals in Canada, certainly in Ontario, rely heavily upon a good stream, the teaching hospitals in particular, a good stream of highly skilled yet pretty inexpensive house staff. The job a resident does in the hospital, all hours of the day and night, weekends, generally give great patient care and come at a very reduced cost to the hospital and to the government and the province. And if we have a competency-based model and the progression of residents through those models is not consistent, it'd be hard for the hospital to figure out, are they going to have enough residents to cover the call schedules, to be there when the 10th patient with their COPD exacerbation needs to be admitted through the emerge, and that 10th patient doesn't really meet the milestones or the EPAs of any of the residents going through the internal medicine service. And now who's going to be left to actually admit that patient? Will it be the staff supervising them? Will it be a hospitalist? Will it be an advanced care nurse? I don't know who's going to do that job if residents aren't necessarily there to do the service aspect of their role. I think another aspect that is going to be a challenge for competency-based education is work hour restrictions. Just this past week or so, National Task Force with regards to duty hours released recommendations. And some of those recommendations may make or may conflict with a resident's desire to get as many cases and much exposure as they possibly can in the quickest amount of time to get through that potentially, example, time-free type curriculum and progress more rapidly through a program. That may be challenging when the residents will have the number of hours that they can actually be in the hospital restricted by either legislation, unions, program-based rules, hospital-based rules. So this is all just coming out now, and we'll have to see how this interacts over the next number of years. And I imagine there could be some conflict between these two seemingly opposite directions of resident education. As I mentioned earlier, one of the greatest differences between the traditional model and the competency-based model is evaluations. Huge volumes and frequency of evaluation for residents in a competency-based model if it's to be done properly. But somebody's got to do it. And just getting faculty to do one evaluation of a resident over a 1 month block at times for certain faculty can be even a challenge. Getting multiple faculty to do multiple EPAs on multiple residents multiple times, that's going to be very challenging. And somebody's got to set that up, administer that, and somebody has to pay for it. It's not volunteer work that faculty do, and time to do the evaluation is time that can't be spent doing something else. So resources, financial and otherwise, will likely have to be leveraged to get this done. And I think the costs, even as I alluded to in the last slide, are really uncertain. Certainly the residency could be shorter, but for certain of our residents, it will be longer in a competency-based model, potentially, especially the time-free models. Who will do the work? If residents are more rapidly put through the program, or the residents aren't necessarily required to do certain aspects of training because it doesn't fit within the milestones or the EPAs, or they're more motivated to do rotations or do things that do fit within the EPAs, leaving other maybe less educational aspects of a resident's life to others. Who will do that work? And I mentioned faculty are not for free. Faculty will require compensation to administer these evaluations and do these evaluations. And I'm not certain that the ministers of health in the provinces have thought about this, because certainly cost savings may be there if a resident goes through a program quicker, and I think most residents probably could, if being as highly motivated as they will be, go through programs quicker. Some won't, but I think probably it'll average out to being a little bit faster through this type of model. But I think the other aspects of the costs, who will do the work and paying the faculty and the resources to get all this done, may not make this a cost-saving model. My impression, thinking about it, will be that this model will cost more money. Maybe not in resident education costs, but in all the other costs with regards to healthcare and education and healthcare. And I think the biggest challenge will be a change in culture for everybody, the hospitals, faculty, realizing that being more critical of residents may have an impact in the residents' progression through training, realizing that residents may be more motivated to do certain things and less motivated to do others based on what their milestones or EPAs may be. Certainly residents and the resident unions in the country may need to change the culture of passing through a residency and realizing that your colleagues may move slower or faster than you when you start as a PGY1, and that will be a big challenge for a lot of people to realize that others may be doing better and moving through the program faster than they are. That may be a real challenge for people to deal with, and I think the hospitals too will need to change the culture within the hospital about how the residents function in the hospital environment. What will the role of a resident be in a competency-based curriculum in the hospital? What will be the service to education ratio? Residents are still paid. They're paid employees of a hospital to some degree, I'd say, depending on what province you work in. And what's the expectation of that payment? And how will that interact with what the residents do with regards to their job in the hospital caring for patients? So that was the end of the presentation that I gave to Grand Rounds in Critical Care on June the 28th. And I hope what I've said has been somewhat educational. I think it's relatively new for a lot of people, shocking for a lot of people that this change is coming, but it is coming, and all the program directors and specialties and hospitals and universities across Canada are going to have to move fairly quickly over the next number of years to get themselves in line with this. And again, I think this is likely the way forward in training in Canada, but there are certainly going to be some big challenges, and remains to be seen how or if we can overcome all those challenges. So thanks very much for listening, and I hope it was helpful.